Yep. Good evening, everybody. It's another Friday, and we are here together with Dr. Vimal Raj as a radiologist and Mithun, my dear friend, as a rheumatologist. Today, we didn't have any pathologist, and we don't have actually pathology slides also, so we do not have pathologist today. Dr. Murli Mohan will be joining in a short while. We already have got Prahlad Prabhu Desai from Lilavati Hospital and Rajan sir, as usual. Good to see you, sir. We'll start with first case. Case 1 and case 2 is by me, so I will finish my cases and then we will move on to Revti's case. Just give me a minute. I'll share my screen. Yeah. So these are the first case is interesting case of one young lady who came to me. So she is a 41 years old lady from Kerala, homemaker. Why I have put a picture, I'll tell you, because I also am not from Kerala, but I somehow found out from the internet that this is what she was exposed to. She was diagnosed as NSIP from outside. Now she told me she is exposed to this kind of yellow flowers. Because I am in Kerala for last almost 10-15 years, I know I had seen these flowers. This is called acacia flowers. What happens is wherever these flowers are there, the road will be there will be a carpet of flowers on the road because of there are small flowers you can see here, and it can cause interstitial lung disease or allergic problem. That is what I understood. It is called acacia. I don't know the other local name of that also. But she shifted to a new house for last 3 years. In front of her house window, this particular flowers are there, and now it is because she thought this is happening. She is actually wearing a mask in the home also. That's what she told me. So this is her background. In February 2023, she was started on Omnacotil 20 milligram and stopped over 1 month. Very fast tapering, but she told that she was much better after that. She didn't have any clinical features of CTD stigmata and no pain in joints or anything. When she came to me, she had exertional shortness of breath for last 3 years and last 1.5 months some worsening. She had initially some difficulty in climbing stairs, but it was not relevant to myositis or anything. Uh, because of breathing difficulty, she had even walking on a speeding on level ground. History of biomass fuel and roadside dust. History of childhood asthma. Basically, it was looking like asthma. One abortion history, but it was not in the first trimester. When I examined her, she had 98% saturation on room air. Her other vitals were stable. Now, this was her profile, and Mithun is there. Mithun, can you please read this for her, for us? ANA was IFA 1 plus, RF factor was negative, blot was negative, anti-CCP negative. These were all done outside. Only myositis profile was done in my hospital because it was not done outside.
Yeah, ANA is basically a low intensity positive ANA. Usually we consider 2 plus and above. If the intensity is there, we consider 2 plus and above as significant. And this is 1 plus, therefore may not be significant. And coming to the myositis profile, there are a lot of low intensity positivity. As I told before, usually the myositis antibodies are mutually exclusive. And if it is significant, one of these antibodies will be strongly positive and others should be negative or low intensity positive. And if there is a multiple autoantibody low titer positivity, then it may not be significant. We cannot take this myositis profile as significant.
So you feel that multiple low titer positivity, it is negative.
We cannot interpret much.
Okay.
If in this case, if this Mi2 and is 1 plus,
Okay, good. Thanks for that. So this was her spirometry. FEV1 and FVC ratio were around like FEV1 was more than FVC. I'm sorry, I have not put the result. But her DLCO was not decreased, actually increased, but KCO was decreased. She didn't have any desaturation. This is January, and then she came back to me in February also, and there was no much difference in both the spirometry as such. Now I'll move on to CT image.
So this is the CT image of 41-year-old female. In the mediastinal window, we are not seeing much at all, no significant lymph nodes or any cardiac issues. Everything looks normal in the mediastinum. And when we look at the lung parenchyma, I'll just put these two images together because one of them is an inspiratory and the other one is an expiratory scan. So the one on the left-hand, what you can obviously see from the start itself is that there is significant mosaic attenuation. Large areas of air trapping are seen in the lungs bilaterally, with some interspersed areas of ground glass opacities. And what is extra on top of these are these right upper lobe regions across here. There are some nodular infiltrates also. You can see across here. I'll just try and zoom that in for people to see. It's a little bit of nodularity associated with these areas, while these are all just standard areas of ground glass opacities with mosaic attenuation. There is no septal thickening, there is no lung cysts, there is no honeycombing, and it's predominantly bronchocentric, mid zones, upper zones, everywhere it's involved. Uh, so overall, what we are seeing is extensive areas of small airways disease with superspersed areas of ground glass opacities and some patchy nodular changes in the upper lobes in a peribronchial distribution. So I would be thinking more in terms of a hypersensitivity pneumonitis kind of a picture in this, with extensive background of airway disease that we can see.
You feel both are coexisting, sir? Huh?
I definitely small airways disease is there. There's no doubt about that. That is what we are seeing in here. But these
Triple
nodular
density, yeah.
changes and across here, that makes me think more in HP also that I would like to bring in. Not just simple airway disease would not give us that.
Okay, okay. So, Rajan sir, actually, now I also I will show you what I did is when I saw the CT scan, my impression was also small airway disease. And what I started is some inhaler which will reach to the small airway. And I didn't start her on steroids, not yet. So my question was, is it hypersensitivity pneumonitis or small airway disease? Do I need to do biopsy? I have not done even bronchoscopy yet. I just gave her inhaler which will reach to the small airways, and I have not given steroids. I didn't do FOB. I didn't do BAL. I didn't do biopsy. So my impression, my questions to the panel is this: that do I need to do all those things or a repeat CT scan with treatment? Almost 3 months she is going to finish with my inhaler, which I believe will reach or treat small airway disease. So whether a repeat CT scan will do if it gets clear, or should I do more than that? I'll stop sharing my screen.
So, Asmita, I
Yes,
was
sir.
just looking at the HP consensus diagnosis statement, and I think you have a low confidence of HP on this with
Yes,
your
sir.
history and the scan images.
Okay.
So, I think if you want to go to a moderate confidence level of diagnosis, you'll need a BAL at least,
For
is
lymphocytes. Okay.
is my view. I think
Okay, sir.
that's short of a biopsy. If she's not agreeable to a biopsy,
No,
probably a
she will
BAL.
agree. I didn't do. She will agree with whatever I say. I didn't do
I,
because I wanted to confirm if it is small airway
yeah.
obstruction, why should I subject her?
I think she's young. I would probably consider a cryo here because you have access to cryo also at your center.
Yes.
She's agreeable. I would probably, then you can get to a moderate to high
Okay.
confidence level diagnosis. Prahlad?
Actually, I'm a little surprised by our lung function test reports. Okay.
Yeah, that I couldn't understand at all, Asmita. Yeah, just get.
I also don't know, but I will repeat it, sir. Sometimes somebody,
Do you have a flow volume loop of that patient?
I might have.
Do you
One
have a
second.
flow volume loop?
Yeah, 1 second, sir.
Okay.
2186 281 8647. So this is her DLCO report, and I believe this is her flow volume loop.
Okay. And does the TLC also reduce, or are we, or you have
TL,
only done the total lung capacity?
TLC is 158%, sir. RV is increased. That is why I thought it is smaller. Like
This
this
is
was
normal. What about a walk? Does she desaturate, Asmita?
98 to 96. That's what happened. One
So
second.
she has absolutely normal lung function, Prahlad.
So
Yeah.
normal lung function. Yes, yes.
Yeah, that is
With a
actually I
normal
was
lung
also,
function,
yeah,
with hardly any symptoms,
I
even
was
your
confused.
bronchoscopic lung biopsy, maybe even, whether, why not you treat her first with the simple inhaled steroids and see what happens to her? Can
Yeah, that
sometimes
is
be,
what I thought that I will not give her. This is
yeah.
her this thing.
Yeah.
Yeah.
So if
So
that is the lung function, I agree with Prahlad. We probably want to just wait.
yeah,
Maybe treat her with a fine particle aerosol
yeah.
because HP
I
is
think
a
I
small
started her
area.
on Nistami or something, and I
Yeah.
will just follow
You
it up.
should you start with the Nivioli inhaler,
Nivioli,
Nivioli.
yeah,
and
Yeah.
Niviola,
yeah,
yeah.
it will work better. Or anything if you have cyclosamide, something like that. Maybe
Yes, sir.
Nivioli will be better dose, and higher dose you can use.
Yes, we'll do that.
And then,
So the
then what you're going to do again?
I am
Then you
this
have
going
to
to do
probably
repeat
repeat a
CT
lung
scan.
function and see whether the first lung function was correct or not.
yeah.
And also I will do. Okay.
So the only thing which goes against all of this is these nodules that you are
Yeah.
seeing.
Yeah.
Those nodules do point us away from a simple small airways disease.
Yeah.
So I agree. Actually, sir, when I examined her, now even my radiologist told this looks like small airway disease. Then the lung function is 158% and TLC and 200% of this thing, residual volume and all. So I also felt that okay, let us go with that diagnosis. But in my mind, I was worried about whatever was going on in the lung. So she is telling that for last 2 months she is wearing even mask at home. So one of the treatment is taking away the triggering agent. So actually that is also taken care of as of now. So if we will do repeat, maybe it will be worth doing a repeat CT scan also, because even if the lung function comes normal, it won't give me confidence of not starting steroids, because I want to see whatever was there in the lungs is gone or not, and then I will consider biopsy. What do you say, sir?
No, I
Yeah.
wouldn't agree there. But why would you treat a normal lung function, Prahlad? What you're treating a scan
She
then?
has a symptoms, no? She has
She
symptoms.
had, she
Symptoms.
came, yeah,
So
she
treat
came.
her symptoms with
Yeah.
fine particle aerosol, extra fine
She's
beclomethasone.
happy, yeah, she's happy.
Yeah. And see how she does with that. Is she obese or any
No,
any
no,
other?
no, not obese, not obese.
Right. She's not
Actually, thin
she's
built.
not deconditioned, anemic, nothing.
Nothing. She's
Everything.
perfectly fine. And as soon as we started her on this inhaler,
Yeah.
she came back to me 1 month. And actually, I have already given a CT scan. She didn't turn up yet. Otherwise, I would have put that CT scan also for discussion. So that's it.
Can I
So
ask Vimal, what are the differential diagnoses in such patients of the HRCT? If you say it's not going to be HP, then what it can be else? Can you think about anything else?
You can have hypereosinophilia is one thing which can give us something like this. Of course, small airways disease is another obvious differential diagnosis.
But it will
Um,
not give alveolitis, no?
alveolitis for small airways disease will not. The nodules will not be there. That is something which is very unusual for it to be there.
hypersensitivity will
Suppose
cause
she's
localized
talking
edema.
about that acacia. Sometimes can this be inhaled in a large dose? Can it be responsible for such a combined pathology without any much symptoms or no?
The, theoretically, yes. I haven't seen enough of that specific scenario to be able to tell.
I also didn't know, but I had seen this kind of trees, and what patient told me was government started cutting those trees wherever it was. Maybe Shobha madam can say something because she's from here. So, patient told me that government in their locality there were many trees like that, and people complained that this is causing problem, particularly asthma. So government started cutting.
Yes, Asmita, I have seen patients developing asthma as a result of inhalation of those
Yes,
acacia flowers,
yeah.
dust,
I
dust
that
or
is what
whatever.
I was
Yeah,
told that it
pollen,
causes,
pollen, I mean.
yeah, it causes more asthma
But I
than
have not seen HP before due to this acacia flowers.
yeah. So patient also told asthma it causes allergy. So government started cutting those trees. That is what they told. Then I found out that okay, this is what that tree is. I had seen these trees, but I didn't know it causes problem.
I think we got to go to the next case,
Yes,
Asmita.
sir.
We've run out
Yes,
of
sir.
time, no?
Yep. So case 2 is another interesting case. Let's see from current slide. Yeah. So this is 48 years old lady, again from Kerala. She had multiple comorbidities. She is a non-case of asthma, allergic rhinitis, hypothyroid, and hypertension. She had history of eclampsia, pre-eclampsia, and nephritis at the time of pregnancy, multinodular goiter since 2012, not operated for the same. She had other irrelevant history also, which I'll skip. She presented with increased cough and dyspnea. And when I saw her, she had something like this. Look, this is not her first visit. She is coming to me for last 1.5 months. First, we did. She belongs to ex-serviceman benefits. So every time she will come, I have to give a clearance paper. She will go. She will come back. So first I did CT scan, and then actually the CT scan was done first, which was showing some kind of ILD. Then next time she came, I told her we will admit and we'll do investigation, which she was not willing. Now this is third visit, and this time she went again and came back from the sunlight. 2 or 3 visits, and this is third visit. I found out that this time she complained she had some swelling around her eyes, and she wanted to see ophthalmology. And then I sent her to ophthalmology. Then she came back, and then I found that it is not unilateral, it is bilateral. Then I sent her to Mithun that is it this heliotrap rash? And then this was her hands, which I am seeing third visit. Okay, so this is third visit, and I felt this can be mechanic's hands, and this is Gottron's papillus. So actually, Mithun also had seen this patient, so I would like Mithun also to say what exactly he find in this.
Ma'am, in this patient, no, what the striking feature was the periorbital edema. Whether it's clear in the X-ray,
Uh,
especially on the left side. If you have if
yes,
you
that
can
is what she
zoom,
was complaining. Yeah,
yeah.
I know.
There was
Yeah.
a significant edema over the periorbital. This area, you will get that is with a reddish rash that can be
Yes.
seen in the X-ray, the photo. And above the eyelids, there was a rash, a faint rash.
Yeah, there was. I have put those things because covering. Yeah.
This appearance is very typical of heliotrope rash. Heliotrope is basically a violaceous rash, but in our population, we say little bit darker. And sometimes, as this patient is a little fair, we can see the red rash, and it looked like a heliotrope rash. And that edema is very characteristic. That if you have that edema, then it is very suggestive of a heliotrope rash. And look at the hands, especially the radial side. You can see the very hyperkeratotic lesions. One differential is you can have a eczema, but based on this background of ILD and heliotrope rash, you should strongly suspect a mechanic's hand also.
And this Gottron's papules looks like something like
And
this.
yes,
Yeah,
and
that is.
around the knuckles, there is a hyperkeratotic papules,
Yeah.
which is which is most likely a Gottron's papule. As I
Yes.
said, another DD is eczema. Eczema also can have similar features with a mechanic sand and the patch over the this PAP joints on DAP joints.
She was a non-case of psoriatic arthritis, the distal interphalangeal, the history
But
which I skipped.
yeah, but this
Cannot be
doesn't
explained.
doesn't look like a psoriasis.
Yes, that is what I wanted. So,
Could
so
the heliotrope rash be also over the eyelids, Mithun?
yeah,
Yes,
he
yes,
had,
yes,
she had,
yes.
she had
She
actually.
had.
She
She
had. I
had.
have covered it because of the
Over
identity.
the upper eyelid. Upper
Yeah.
eyelid, you
Yes.
can see a rash.
And this around the nose also, if we see na, sir, she had actually, you can see it crosses. That is how we differentiate the
Malar rash.
Mala rash.
lupus rash from this rash. Yeah, that is what it is. It will cross the midline. Yeah. It was very classical, but having said that, we both missed, and then when she went into sunlight and came back, it was very obvious. So what I'm trying to say is it's you look for it, you will find it. So other than that, her examination was relatively okay. This is her ANA profile. ESR was 49. Other than that, everything was fine. Now this is her myositis profile, and Mithun can say again.
And we examined for her proximal muscle weakness also. And
Yes.
surprisingly, she didn't have any muscle weakness.
You did
And
CK also, na? CPK.
CPK was also normal.
Hmm.
And myositis profile, this is, as I told, it's a very low titer positivity. Nothing can be interpreted from this myositis profile.
Hmm.
However, based upon the clinical finding, we came to a diagnosis of clinically amyopathic possibility of a clinically amyopathic dermatomyositis. That means you can have the classical dermatomyositis dermatological features without muscle weakness or muscle enzyme elevation.
Yeah.
CADM.
Yes.
In CADM, you can have myositis antibody negativity also, and anti-MDFI is another autoantibody known to be positive in CADM. It can be myositis antibody negative myositis also.
Yes, her
That is
actually,
our clinical diagnosis.
yes. And we actually, she was also not willing for bronchoscopy. Look, there are things that guidelines says that you do this and you do that, but there are some practical difficulties. Even 3 visits, I could not convince her, and we have to start her on immunosuppressant because we were almost convinced this we are dealing with CADM. This was her lung function, and you can see DLC was 45%. She was desaturating. She was complaining of severe breathing difficulty by the time she came to me for third time, and I would like Vimal Raj sir to share the CT scan also. CT was done first, and then we found out that this is also happening.
Okay, so this is the 48-year-old female, and what we can see on this screen, let me just show this first. There are a few prominent mediastinal lymph nodes. We can see going up to the subcarina. The main pulmonary artery was slightly prominent around 3.1 centimeters, but there are no other features to suggest underlying pulmonary hypertension. When we look at the scan, so the left one is an inspiratory scan and the right one is the expiratory scan. So if we focus on the inspiratory scan first, what we can see here are these large, dense areas of ground glass opacities with associated bronchial dilatation extending in the mid and lower zones, extending all the way to the periphery with minimal subpleural sparing that we can see towards the lung basis in these patients. And when we look at the expiratory imaging, there are not that areas of air trapping, these are actually areas of spared lung, which we can see across even in the pre-inspiratory scans also. So diffuse ground glass, no honeycombing, no cystic chains, there are no nodules. The fissures are clean that we can see, and the disease is predominantly mid to lower zones. All of this is fitting in with a inconsistent with UIP. This is like a CTD ILD pattern that we are looking at. When I looked at the notes that Asmita had sent across, and there was a question of, is this a simple CTD ILD or is this an amyopathic dermatomyositis? The differentiating features between these two on CT are usually amyopathic dermatomyositis has NSIP, which is ground glass, with organizing pneumonia pattern. That organizing pneumonia pattern is not very apparent in this case. It is more of a CTD ILD. So I'm not going to be able to differentiate one from the other.
Yeah, I'll just share my questions. I forgot what that.
Dr. Vimaraj, I'm just wondering, this perilobular ground glass, could it be due to perilobular organizing pneumonia? We can see the nice lobules, actually, the spread lobules. I mean, there are perilobular constellations and ground glass. Could it be due to perilobular organizing pneumonia?
So the background of NSIP pattern itself is organizing pneumonia. So organizing pneumonia is what leads to NSIP. So whenever you see NSIP, there will always be, on biopsies, you will see organizing pneumonia pattern. But for the differentiation between these two, it needs much more denser areas of organizing pneumonia than what we are seeing.
So the
Thank you.
questions were like, as sir told, it is for the panel that is it CADM or we can just label it as NSIP. And do we need lung biopsy? Because as such, it is inconclusive. CTD profile is inconclusive. And we started both, na, Mithun? We started steroids and MMF, or you started only steroids?
Steroids and MMF.
Yeah, we started steroids and MMF already. So now what else? Because we were worried that we can't wait any further. Her breathing difficulty was worsening.
But then you need to tell us if she's better because you've already done
2
what
weeks,
you
na?
asked.
She didn't come back, sir. I will tell you next time.
So,
So,
I mean, I don't think I would have done a biopsy on such a patient.
okay, sir.
Prahlad?
Yeah.
No, but Smita, a patient is affording, and then the whole body PET scan would have been a much more good investigation for such patient because of we can come to know about the lung and also the lymph nodes, and also some, is there any other extra pulmonary features are there, because she's not very classically fitting into dermatomyositis polymyositis, but her clinical features of face and the skin is favoring dermatomyositis like lesion. Somehow
I think the clinical features strongly support dermatomyositis.
yes.
And in the presence of that, even a 1+, I would be tempted to say is, pushes us in favor of a CDAM. But I'd completely agree with Dr. Prahlad that the PET would probably be the way to go, given its associations with malignancy also.
Yes. That can be
Malignancies,
done.
yes.
That can be done.
Correct.
That can be done. That can be done. And affordability is not an issue because, as I told, I have to write the clearance papers. That's it. Okay. So I'll do that and we'll move on to the third case. And presently we have started treatment. We will get back to you about the treatment response. Case 3 is presented by Dr. Revati. Thank you so much, Revati, to be here. And I will just share the screen. Can you see it?
Yes, ma'am. Thank you.
Yeah, please go ahead. Yeah.
Thank you, ma'am. This is a case of a 79-year-old female. She is a religious nun who shuttles between Italy and India. She spends almost 10 months in Italy and 2 months probably around this time, Feb to April in India. The past history is that she's been diagnosed as sarcoidosis in 2009, which she gives history as biopsy was done from her skin, most likely her upper limb skin. Unfortunately, we don't have any reports from there, nor does she remember exactly where the biopsy was taken from. But the biopsy was done at St. John's, and they've told her that she has sarcoid, and she didn't require any immunosuppressants then, just routine follow-up. But unfortunately, I think because she's been traveling between India and Italy, she's not been able to follow up. The other significant history is that she's a case of ischemic heart disease on blood thinners, hypertensive, diabetic, fairly under control. She has a sliding hiatus hernia with significant amount of GERD. Actually, she was admitted for a gallbladder polypectomy because during routine scan they found a polyp in the gallbladder, and she was admitted for the same. The only positive history which she gives is of a dry cough, and hence she was also evaluated for the GERD, and endoscopy has been done, and the gallbladder polyp was removed, which I think I sent ma'am the slides of which the pathologist had found prominent lymphoid follicles in both the gallbladder wall as well as the gastric mucosal biopsy, which they were also suspecting whether it is IgG4 related disease, but the IgG4 staining was negative. Now, the dry cough is the only symptom. She has breathlessness on exertion, but to be fair, she's also slightly on the more obese side, and some amount of numbness on walking, for which we asked for an NCV, which is still awaited. So the autoimmune markers, which are done recently because we don't have any of the old autoimmune markers, her RA factor was significantly positive, anti-CCP is negative, ACE levels were normal, her ANA by IF is strongly positive, and ANA blot is showing this anti-Q strongly positive. We have 3 of her PFTs. It's a restrictive pattern ratio of about 84%. FEV1 about 93% in all 3 scans, but our FVC in 2018 was about 1.31 liters, in 2022 1.43 liters, and currently we've done including a DLCO, where 69% is the FVC and DLCO is 51%. Ma'am, you have the CT scans as well as, I think this is just, I don't have the blot photos, unfortunately.
Sure. No problem. I think, yeah, I'll just stop sharing.
So this is the CT scan that we have. And when we look at the mediastinal windows to begin with, age-related atherosclerotic changes, there is a stent in the right coronary artery, no lymph nodes, and upper abdomen also has very small volume lymph nodes. The right heart is normal, no features of pulmonary hypertension. When we look at the lung parenchyma, what we are starting to see are these areas of traction dilatation of bronchi in the apices, cluster of these areas which are forming some cyst-like appearances, but these are all bronchi which are getting dilated. And as we go down, these are all multifocal areas that we can see. And as we go down, similar changes are happening even in the right middle lobe. You can see some focal areas of bronchial thickening and dilatation. And then here is where we start to see some interstitial changes, where we're seeing these cluster of cysts which are layered on top of each other and don't necessarily reach up to the bronchi in the right lung base. Similar changes in the left lung base. No ground glass, not much in terms of nodules that we can see. So this is one calcified nodule in the left fissure. So looking at this, very atypical features. This does not look like a sarcoid in terms of distribution and pattern. It is something which I have seen in some patients with CTD, ILD, scleroderma. Sjogren's also sometimes gives this kind of clusters of cyst towards a subpleural aspect. So mild interstitial process, inconsistent with UIP, I would think about CTD associated ILD in this patient.
Thank you, sir. So the questions which I have are the ANA positivity, the anti-CO positivity. Mithun sir, there's this, I mean, can we label this as Sjogren's because she doesn't have any symptoms of dryness, nor does she have some amount of oral dryness, but then she says that increases during her increased periods of GERD. She doesn't have it constantly. We've not done a scrimmers or anything on her. So how do we go forward with
this antibody anti-Q is more strongly positive, no? Anti-SSA is less a borderline positivity. Therefore, Q is the major antibody positive in this. Q is associated with usually with a overlap syndrome.
Okay.
And rheumatoid factor is also positive. Same. It can be seen in overlap syndromes. Overlap syndromes means patient can have features of two CDDs.
Okay.
That is the overlap syndrome. And what all that other these one can be the Sjogren, other and does he has any features of arthritis? No.
No, nothing. Some a minimal amount of fibromyalgia sort of symptoms like
CPK?
no sir, CPK is normal. We've done one when she was admitted.
Okay.
So could there be overlap with some sarcoid, Mithun, here? Because she had a previous diagnosis of sarcoid.
Doesn't fit in. This antibody profile is a strongly positive rheumatoid factor and this thing.
Yeah, and also the mucosal biopsies from both sides do not show any non-caseous granulomas or non-caseous granulomas. That was one thing. And the second thing was the history is suggestive of skin biopsy. Now that I don't know if it was an erythema nodosum in the past or whether it was clinically fit as sarcoid. We don't have any history from there. So now the question is, do we have to treat her? Do we have to give any immunosuppressants? Because she is having significant restriction. The main troubling symptom is a dry cough, which despite giving PPIs for the GERD is not improving. So do we have to treat this ILD and how do we further evaluate the symptoms of the case?
I don't see anything on the scan that merits treatment, Revati, to be honest. But, this could even be a burnt out ILD on the scan. I'm not sure if this cough is related to the interstitial lung disease at all. I agree you have a lower lung function, but if you look at the serial lung function, I don't think it's progressed, has it?
No, but we don't know the DLs. The FVCs have not dropped since 2010, but 2018, sorry. But the DLCO, this is the first time we're getting one. So
yeah, and this cough has increased since how long? How many weeks, months?
So she has cyclical cough episodes, so every 2 to 3 months. And the thing is, there is a history of some tapering medicines given in Italy, which possibly may be steroids. Now we don't have papers from there also.
What about her skin? Is it skin tightening or
nothing?
Nothing.
Now there are no skin lesions. Some dryness on the skin, but other than that, no rashes or no lesions.
Based on antibody alone, you cannot treat. Treatment should be based upon the symptoms or the organ manifestation.
The symptom is cough, which is not responding to the PPI. So now what do I put her on is the question.
GERD is well known to be associated with these anti-Q, these scleroderma-like diseases. Q can be associated with scleroderma-like diseases where the skin tightness may evolve and become soft after some time because the patient may had some skin tightening before 10 years back. After some time, we cannot actually recognize whether the patient had any skin lesion at all.
Okay.
And GED can persist. Raynaud's phenomenon can persist. Like ILD also can persist.
Does she have Raynaud's?
No history of Raynaud's.
Prahlad?
I think symptom point of view we have to go. But if treatment has to be considered, then I certainly would like to add a small dose of mycophenolate and a very small dose of steroid to see the response to steroid. It's worth seeing the response to steroid as well as consider, because a cough may respond very well to this.
But she's 79, Prahlad. Yeah. Do you really think the
small dose of steroid? She must be taken also in the past.
Yeah, she's giving history of taking tapering doses from Italy. Now, I don't know whether it is, it must be steroid. What else can be tapered?
She's an Italian or an Indian?
She's a Malayali who works for the Catholic congregation. So she's most of the time in Italy.
Okay.
Murlimon, sir.
Yeah, so I was thinking, what Dr. Prahlad said, a small dose of steroid will help her cough if that's her main complaint. Aggressive treatment of her GERD. I'm wondering if it's worth doing Dr. Mithun can tell us if doing a salivary gland biopsy or a lip biopsy would actually help, considering there was some lymphocytic infiltration in the older biopsies, the gallbladder, and there's certainly a discrepancy between what we are seeing on the scan and the lung functions. A huge difference. In fact, I wanted to ask Vimal. Vimal, that pulmonary artery is rather dilated, isn't it? Should we be looking for pulmonary hypertension in other ways also? She had an echo which looks for pH, because that would explain the low DLCO.
The pulmonary artery actually is not that dilated. It's actually just 2.4.
So the
Oh,
PSP was also about 35 on the echo. We've not
which
done
is which
PSP.
is normal, just upper
Yeah.
limits of normal. Okay. Yeah,
I-
so I think aggressive management of her GRD and a low dose of steroids to test her.
Okay. And then repeat with the PFT DLCO and then have a look, sir.
Yeah, I would hesitate to start her on MMF.
Okay.
As Sujit was saying, at 79, not really sure if how well she'll tolerate it and whether it's going to make a big difference.
When you are starting steroids, you should also consider the osteoporotic risk, and you should give prophylaxis for that also. 79 is too old.
Yes.
And in these cases, the GRD can be really troublesome. And scleroderma GRD, we need to add multiple agents to control the GRD. That is well known.
And
I'm
also, I
not
feel
sure.
more comfortable with mycophenolate rather than steroids, actually, giving to see symptom response. I mean, because of this age and the reflux and everything.
Vimal, there's no hiatus, isn't there?
There is a sliding hiatus hernia. And
There
she,
is a sliding
yeah.
hiatus.
There is a small hiatus hernia, yes.
Yeah, okay.
Yeah, Vimalraj sir, I was seeing the liver. Don't you feel it was very nodular and all? I'm sorry, but I felt like that.
No,
Smaller in size and nodular and all. No.
not
Okay.
in this patient. It was in the other patient,
Okay.
not in this patient.
Okay.
So the consensus being that treat the GRD more
Aggressively.
Start a small dose of steroids to see symptom management and to see if the symptom response is there, and repeat a PFT in maybe 3 to 6 months.
Sure.
I would probably wait for the response to the aggressive GRD management before starting steroids, considering her age. I mean, that's my
Yeah.
opinion.
Okay.
I also support the same thing.
Yeah.
I'm not sure about.
Logical.
And
Yeah.
so, any point in doing a salivary or lip biopsy?
Salivary gland biopsy helps you to diagnose something, but treatment-wise, it will not help.
If you want.
If you want to prove Shogun or overlap, you can do that. But based upon that, you cannot decide on any treatment. Here, you want to know whether your lung will improve with your treatment, no? Whether you need to treat that. For that purpose, the lip biopsy will not help.
All right. Okay. Thank you, sir.
Thank you. Moving on to the fourth case by my friend Dr. Shobha. Madam, I believe slides will be visible. You can start. Yeah. Over to you, ma'am.
Yes, good evening. I have got a 77-year-old male hailing from Kerala, ex-serviceman. Background history, he has been hospitalized for a sealed duodenal ulcer perforation in 2018. He came in April 2024 with 4 months history of dyspnea on exertion, grade 2 to grade 3. He had lots of cough with whitish sputum and was not able to walk for more than 5 minutes due to breathing difficulty. He was also complaining about lot of tiredness and fatigue. There was no other positive history. Exposure history. He was rearing pigeons in his flat. As he was staying there alone, his wife had died, and he kept pigeons as well as so many other birds in the flat. And he had close contact with many of them, and he was continuously exposed to them over last 2 years. Then he developed these symptoms after this exposure, and he is an ex-smoker, 25 pack years. He quit 5 years back. On examination, he had grade 3 clubbing, SpO2 91% on presentation, examination, bilateral crackles and squeaks. Lab results were all normal. ABG showed reasonably okay, a PaO2 of 71. And this was his chest X-ray and on presentation in April 24. And yeah, CT, I have already sent it for discussion. This was his CTD workup, grade 3 ANA fine speckled. All the others were negative. And that was the PFT. FVC is 58%. DLCO and 6-minute walk test were not done since ECHS doesn't allow DLCO. And he said he can't walk.
Yep.
He refused to take the 6-minute walk test.
Okay, I'll stop sharing and maybe sir can show the CT scan and we'll take the discs. You are muted?
Shobha, this is the first time he has presented to respiratory OPD?
Yes. April 24.
April 24. Okay.
So this is the CT scan from April 24, and what we can see at that time is the esophagus is dilated. There is some thickening of the walls of the esophagus. It tapers down as we go lower down, but then there is a largish hiatus hernia that we can see in this patient. And when you look at the liver of this patient, liver is a bit too bright, and there is this nodular outline to the liver, and there is caudate lobe also, which is prominent. So some form of chronic liver disease in the background. The pulmonary artery at that point in time measured around 3.6 centimeters. So some features of pulmonary hypertension had already set in. When we look at the lung parenchyma at that point in time, what we can see are these diffuse interstitial changes where we are seeing traction dilatation of bronchi with honeycombing in the subpleural aspect, starts at the upper lobes with some interspersed areas of ground glass opacities, which we can see here, and traction dilatation of bronchi. And as we go further down, we can see these areas of diffuse ground glass, and extreme lung bases are relatively spared. So this is one of those which we talk in terms of, four corner sign and a lot of ground glass, which is like a CTD ILD with a UIP pattern that is getting established at this stage, with chronic liver disease, with pulmonary hypertension in this patient. Would look for any history of amiodarone use because the liver looks a bit too bright for me, and that could be another thing at that point in time.
He had no other medical history. He's not on any drugs before he presented to me.
Okay.
Vimal, that left atrium also looks rather big.
1 second. Not that big. I'll just measure it as well because it measures around 3.8. 4.5 is the upper limit of cutoff. And I think it's just the angulation in which it is.
Okay. Because on echo we say 39. So
Yeah.
Okay.
And is there any family history of lung fibrosis? I mean, because of this chronic liver disease and UIP pattern, is there any short
there is no family history of any relevant fibrosis, no family history.
Thank you.
And I asked for the CTD workup, and before it was available, I gave him 3 weeks course of 30 milligram of steroids, and then he disappeared for 10 months. He did not come for any follow-up. All these CTD results I could get from the system only. So he went home. Apparently, he was feeling better. I don't know how, but then his next visit is on 25th February 25. He complains of cough with expectoration since 10 days, increase in shortness of breath since 10 days, and he was dyspneic at rest. Saturation was 61% with severe hypoxemia. And I think that X-ray is showing
significant
X-ray and
yeah.
CT scans, I think I have sent already.
He had stopped the steroids and all that, Shobha?
Yeah, I gave him for 3 weeks
And
and
he's
asked him to come back for review, but he never came back.
sure.
Yeah. You are muted again, sir.
Sorry, yeah.
Yeah.
So we are looking at the comparison ones. This image is from 2025, recent one, 28th of February, while this image is the April 2024. And what we can see are the similar changes, and there is subpleural honeycombing, upper lobes, and patchy areas of ground glass. I'll come back to this area in a second. And what we can see in the lower lobes,
Thanks, Shubhra.
the disease has become much more of
Yeah.
honeycombing, which wasn't the case before. Now it has gone into what we would term as exuberant honeycombing in the lower lobes, with again extreme lung bases seem to be spared in keeping with an NSIP pattern. I'm a little worried or would like more evaluation of the. I do not have contrast images. The hiatus hernia remains in this patient. The chronic liver disease is also unchanged, and the pulmonary arteries are also pretty much same. They're not changed. So here in the left upper lobe, we are seeing now focal areas of soft tissue thickening and consolidation. Most likely that this is going to be infection, but we will need to keep an eye on it to make sure there is no neoplastic process which has come over. So in overall, I would say that this is a UIP pattern with a CTD, underlying CTD disease, exuberant honeycombing, four corner sign that we can see. And there is definitely disease progression with the fibrotic component being much worse than what it was before.
Yep. Okay, let me see the questions if it is. Yeah. Panel can take diagnosis and further management.
So I'm wondering what the working diagnosis was in April 24 that Shobha had. She probably wanted to see if there's any reversible component by
Yes.
giving steroids.
Yeah.
But that background honeycombing, four corner sign, as Vimal described, probably go. I mean, he's in the age group for IPF. He's an ex-smoker, but his smoking stopped, and then the pigeons came. So it's all like HP risk goes up obviously with pigeon exposure, but I'm not sure if this is how HP looks. Vimal, anything to suggest HP on that scan, Vimal?
No, we've done expiratory images also. There's not much of air
Nothing.
trapping in this
So
patient.
this is, yeah, so then this is not HP. We have an ANA that's positive at 1 in 320. It's strongly positive. Yeah. I don't know if this is a progressive you did the myositis blot as well?
Yeah, everything else is negative.
Everything else is negative, yeah. So he's obviously progressed in the fibrosis and he's deteriorated because of the left lower lobe infection now.
Yeah, he's on antibiotics. Sputum grew Pseudomonas, and clinically his cough and sputum is coming down.
Right. So he's getting better with the current treatment of the infection. But what is the background lung disease is obviously got worse with smoking. Even smoking-related interstitial fibrosis doesn't have so much honeycombing usually, from what I've seen. So I don't know what the working diagnosis here be. Probably an atypical presentation of IPF with an acute exacerbation. Prahlad? You're muted, Prahlad.
Typical four corner signs, etc. If you see the first scan, uh, gives an I thought about it's a like an IPAF type of um, clinical impression would be probably interstitial pulmonary fibrosis with autoimmune features. maybe may not be clinically, but definitely the markers are positive and the radiological features are favoring that. And now
But
there's a
IPAF is not a diagnosis, right? That's what
yeah,
we
I know.
largely agree on.
Yeah,
Yeah.
yeah. So idiopathic pulmonary fibrosis, I don't know whether though the background smoking history is there.
I mean, just an atypical presentation of IPF is what I was
Yeah.
thinking. Is he clubbed
Yes.
also, Shobha?
Yes, clubbing is
Three
there.
plus clubbing. 3+. How many days he took steroids afterwards, or he continued?
21 days. 21
20.
days.
Okay.
Madam, what was the baseline ESR and CRP inflammatory markers?
It was all normal, if I remember.
Okay.
But yeah, I'll just.
Classical, na Vimalraj sir. The CT picture is very classical. That exuberant honeycombing and all. We can't miss that.
Yeah,
Can it?
combination of
No, but the whole
anterior
point.
upper lobe sign and
Yes, sir.
exuberant honeycombing pushes you strongly in favor.
Yeah.
You know, it almost doubles the chances that you're dealing with the CTD ILD. And that coupled with an ANA 3 plus fine speckled.
Mm.
The only question is the man seems to be somebody who is not reliable in terms of follow-up.
Yeah,
So to put him on potentially,
dangerous. Yeah,
dangerous medicine
yeah.
is a big worry, and at his age also.
There was
So,
esophageal dilatation, na Vimalraj sir. You told, yeah. Okay.
Yes.
So the only other thing is, as Vimal said, that's probably an infection, but we do always worry when somebody who's been an ex-smoker comes with that kind of thing. And we've seen ILD, associated with malignancy. So that's a source of worry for me.
Yep.
Certainly needs an eye to be kept on it. But I would treat him as, antifibrotic, certainly. The fibrosis has certainly progressed. Given his non-reliability, I would be a little worried about a immunomodulator, despite the fact that I still think it's a CTD-ILD. So if you can speak to family and get assured that follow-up will be maintained, then maybe I would cautiously try that.
So coming to that, sir, because Vimalraj sir was telling me maybe this patient had CLD and all. So now we are doing this short telomeres and all. Patient has CLD, patient has got lung fibrosis. Uh, Again and again, Rajan sir, people are asking, is it commercially available? My hospital also I'm doing on the research basis. We we have to do something to make it, na sir, because it's so difficult to.
even the research lab we are working with, which is ICMR NIH, is validating it still. So they will
Oh,
take till June to get that done.
oh.
But I'm not sure how short telomeres are going to help here. What is the
Because sir was telling about immunomodulators. So if patient has CLD and patient has lung fibrosis, there is a high chance that patient might have even
okay?
short telomeres, and in that case immunomodulator will not help, only
Well,
antifibrotic will help.
so, but correct me if I'm wrong. Maybe I missed this. He has chronic liver disease, this patient.
Yes, he has.
Yeah.
Okay.
It is stage A. So
So,
I
Dr.
have
Shobha, is
started
it,
maintenance.
what is his history of alcohol intake? I mean, you said ex-military smoker, they get rum free, so.
Yeah,
Yeah.
not an alcoholic.
Okay. Sorry. This is just, you tend to think of it because they get it really cheap in their canteen.
Sorry, sir, but even you just from Kerala, you have to ask about alcohol.
So, but I think many patients, we see a chronic liver disease without any cause. Okay, now
Yeah.
either
Yes,
diabetic. Many
yes.
patients have ILD associated with chronic. This is something, and which we probably are not much documented, and we don't talk much about it.
You're
No,
But
no.
right.
In India, NASH, non-alcoholic steatohepatitis, that is
yes,
very common reason for CLD in female as well as in Kerala, in which
right.
who are not ethanol
But
consumers.
many of them are also associated with ILD.
Yes,
Yeah, you're
And most,
absolutely
that
right,
is
sir.
how the
Yeah.
short telomeres came, because we have to look for it. And so you want to you mean to say that until unless it is accredited by NIH, it is not reliable, sir?
no, it's not accreditation. They're validating the test.
Okay.
They're just validating the test they're doing for a research purpose. So they're still validating it.
So you also will do and they also will do, and then You will
No,
validate.
they are doing it and they're valid. I'm not sure how they're validating it,
Okay.
but they're taking some time. I need to call up Kunal, who was there in the meeting
Last to
before the
last, yeah.
last.
Yeah, I know. So, madam,
So
they are telling, yeah.
But that's true what Prahlad
I
was saying that
I have started antibiotics and I have started nintedanib. Should I start
No, no.
steroids? No.
Nintedanib, I think
Will be
probably
burnt.
not be too high it is for this patient. You will develop probably worsening of his liver function.
Yeah, pirfenidone will be a better
But I'm
choice.
monitoring the liver function.
yeah, I
Okay.
think whenever we ask hepatologist Prahlad, the standard response is just monitor liver function and give what you want to give. So
Yeah.
That is
One
what.
question to Mithun and everybody. What is safe? Vicelon 10 milligram is safe or mycophenolate 300 milligram one morning, one night is safe for such patients? Suppose, considering age and considering the liver issues.
Mycophenolate. I
He
feel
is
mycophenolate.
he is
if
good.
you have to go to immunomodulation, I guess, yeah.
Yeah, that is why I asked about that, because immunomodulator doesn't work with short telomeres. So maybe once it is commercially available, it will be very clear.
Yeah, but considering his age, if he's 77, right, Shobha?
Yes, 77.
He's 77, chronic liver disease, lung disease, I would stay away from immunosuppression completely if I can
Okay.
avoid it. And especially as Asmita rightly said and Murli, that if he has short telomeres. Because if he has short telomeres, we will land up in problems there.
Okay.
So just treat the infection, observe oxygen and nintedanib.
Antifibrotic with liver function monitoring.
Okay.
Yep.
Yeah. Okay. Okay.
Okay, I will
Yeah.
go on to the last
Thank you.
case, and we are doing quite well. Most of the times when Bhavin sir is not there, we are good. Matlab, fast. Uh,
So
over to you, Rajan sir.
this is my patient, the last case, 79-year-old male, never smoker, hypertensive, hypothyroid, ischemic heart disease with 2 angioplasties, sleep apnea on CPAP, and his CPAP data card is pretty satisfactory. He has a factory at Silvassa, but he's relocated to Mumbai for the last 4 years. I think it's a plastics factory. He was a regular 10-kilometer walker. Now he gets breathless after a 1 kilometer walk for the last 1 year. He plays tennis, but he tires after now just one game in the last 6 months. He feels tired and sleepy most of the day, which is why we checked the CPAP data card, which was fine. Had COVID twice in the past, both mild, and he was started by a Gujarat respiratory physician. I think it was in Surat on 801 milligram BID of pirfenidone. He had taken prednisolone for 1 year in 2022 and just stopped it. I'm not even sure what his symptoms were that time. I think he had a little cough, nothing major, but he was treated with steroids for a year and then he realized it's making no difference, so he stopped the steroid. These were his bloods, full autoimmune workup done, negative, and he's pre-diabetic. And these are his lung functions that we have for the last almost 2 years now. As you can see, reasonably stable. 70% predicted now, even now the FVC, not desaturating on the walk. So he's come from Gujarat for a second opinion, and I had the CT scan on films of 2022 and the CT scan soft copy 2025, which I think Vimal has.
Fortunately, I do have the 2022 also on CD. So this is the CT scan from June 2022. And in the mediastinum, nothing much, some age-related atherosclerotic changes in the coronaries. There is a large hiatus hernia that we can see. The pulmonary artery is not dilated. And the one on the left, this is the inspiratory scan, and the one on the right is an expiratory scan. What we are seeing is as we go, minor fibrotic changes, non-specific there, but the main pathology, if at all anything, is towards the lung basis. where we start to see these early reticular changes in the lung basis, with not much in terms of honeycombing, cystic change, or even traction dilatation of bronchi. So this was in 2022, very early changes that we can see here. Now, if we fast forward this and bring this across to now, which is 2025, I'll just show you these images again. Upper lobes, nothing much has changed, and minor areas here in the left upper lobe, atelectasis, and the lung bases, slightly worsened changes of these reticulation. We have prone imaging, which are very nice, and I'll just show that to you. So these are the prone images of the patient, and what we can see are these towards the lung bases all along in the subpleural aspect bilaterally. As we come down, you're starting to see these subtle interstitial changes, and further, more and more prominent interstitial changes. The bronchi are reaching up to these areas, so early traction dilatation of bronchi. So diffuse subpleural changes here, you can start to see very early cystic change and predominantly lung basis. No nodule, no mass lesion that we can see here. So all of this looks like early ILD, early interstitial process. I would have put, for the want of a name, I would have put this as a probable UIP that it is developing. There is no honeycombing, there are no nodules, no mass lesion, and the hiatus hernia remains as before.
Yeah. So my question there, he's 79, so I'm not in a hurry to do any biopsy for him, but is immunomodulation likely to benefit at all, is what I wanted to ask Prahlad and Murli. And should I stop pirfenidone considering he hasn't progressed but is symptomatic? Now, my question is really, pirfenidone is not going to help his symptoms of increased breathlessness. So where does one go from here, Prahlad?
I think considering his lung function and his recent deterioration in his symptoms, the player who walks regularly 10 kilometers comes to 1 kilometer, it means significant amount of disability.
Yeah.
Similarly, so I think we should think about something else, the cause of breathlessness. Whether he has got an underlying coronary disease, we should think about.
Sure.
And second important thing is that if the sleep apnea is extremely severe, okay, and he's obese, okay, probably that may also attribute to his worsening of breathlessness. Because the scan point of view, he should not be so much amount of having breathing difficulty.
Yep.
So he's
can we have a CT coronary? Can we have a calcium scoring on such? Should we do routinely actually calcium scoring in a plain CT scan when you do ILD, especially in elderly? Bimal, I think you should answer
that. We should do. Definitely. We comment about it. We don't necessarily. There's no absolute value, but we say mild, moderate, and severe. I'll just quickly share my screen 1 second. I am seeing
I will get a cardiac workup done. I agree with you, Prahlad. I haven't done that. And I also think the symptoms are disproportionate to the CT.
I just want to get more clear history, because something like this, it looks like a stent already in his RCA.
He's had a PTCA twice.
Okay. Yeah. So that stent definitely, in that scenario, then calcium score will really not help us if they already have that.
So functional cardiac evaluation, Prahlad, Murli?
Yeah, absolutely. Check, his NT-proBNP, see if it's very high. Get perhaps a stress echo if he can't walk very much, but he should be able to do it. He's walking a kilometer. Yeah. And perhaps a GLS echo, because, I completely agree with what Dr. Prahlad said. This is disproportionate, or you say also, Sujit. Yeah. Look for other causes. And of course, one of the other reasons is he's got a hiatus, he's got basal changes, is he having recurrent aspirations? Very common in people with OSA when you have them on CPAP, they tend to have aerophagy
Yes.
and aspirate. So that's something I would look at carefully.
Sure.
Just follow up. Certainly don't want him on an antifibrotic again, and certainly not an immunomodulation.
So you would also agree, Prahlad, to stop the antifibrotic?
Certainly, no?
Okay,
Antibiotics.
which is what I told him to. Yeah.
Okay,
Perfect
my
consensus.
one doubt. So I believe that okay, this is disproportionate and all, but you have got a prone images, and that indirectly suggests that anti-proBNP has to be normal, isn't it, sir? Because
Not in.
if it was cardiac failure, you will see it. This
No,
particular
not
patient we
cardiac
have.
failure.
No, that
No, we're
would
not
be
saying cardiac failure.
I'm not saying,
Not
I'm telling anti-proBNP has to be normal. It won't be very high or abnormal in this
Oh,
particular
that way.
patient.
Okay.
Yeah.
Yeah, no, you're right. Which is why I also suggested the stress echo or a.
Yes, that will help. But I also thought anti-proBNP, but we have got a prone images and which indirectly will be saying you about what will be the likely.
If this was interstitial pulmonary edema, I agree, Asmita.
Yeah.
It should those would have been
Sure.
different. Yeah.
Okay.
And further, I'm
But
just
I-
wondering, CPEX, could it be, I mean, are you doing routinely CPEX, cardiopulmonary exercise? I mean,
No, we don't do
we don't do
routinely.
it routinely, but we can get it done in Mumbai. Yeah, Amila, that could be done, but I think maybe a nuclear stress test would be better before that. Or what do you
Stress, yeah.
think, Amila?
yeah, I mean, again, I mean, it's availability of Sri Lanka. It's much more easier to us to do a CPEX than nuclear imaging. So, I mean, I would definitely, depending on the availability, I would say, because that we would like to kind of understand what is the where is the Vmax is limiting, where is the Vmax is getting limited. If it is cardiovascular, we definitely go for a kind of nuclear imaging. But again, it's availability issue. I mean, CPEX is available before nuclear imaging. It's
Interesting. Yeah.
Yeah, that's it.
Nice to know how different geographies manage, based on your availability, what you do.
Yeah.
And I'm always impressed by the number of cryobiopsies you get in Amrita Institute, Asmita, compared to what we
Oh
can
my.
manage here.
No. You once told me that our Udwadia sir, he does once in, like he does even half of yours, and we do for almost 50% of cases. So it as you told, it is about availability, geography, and
Darir has hardly sent a patient to biopsy. Very
yeah.
rare. He's always said that, very rarely to biopsy. But I do think biopsy still has a role, but select cases. Yeah.
Yes, definitely. But we don't want to delay it further. 6:15 and we finished 5 cases. That's great. Thank you so much, everybody. And our next meeting will be 21st, right?
That's right.
Yeah,
That's
21st.
right.
And probably we will have Professor Athol Wills. Yeah, anybody? Sorry? Yes, sir. Murli, sir.
No, nothing. Thank you. I mean, it's been great. I'm sorry I joined late.
That's okay.
Busy
We
OPD.
are happy.
Yeah.
We are happy to have you all, Prahlad sir, and
Thank
we
you.
have made Prahlad Prabhu Desai sir our regular expert, Rajan sir, because I told I need somebody who will be always willing to be coming. Like Murli Mohan sir is really nice, and sir is also very nice, because then we can have some different opinion that
Absolutely.
matters. Yeah.
Absolutely.
And thank you so much, Amila. Your points are really well taken. My one more doubt, sir. I'm sorry for my ignorance, but isn't this dobutamine stress echo also is equally good, sir, or is it nuclear medicine test?
So I rarely use it except for those who cannot exercise. And
Okay.
when my cardiology colleagues tell me they do it usually when they have a fairly sure there is no cardiac problem. It's like a pre-operative functional test.
Oh God.
So it really does not mimic true exercise, which is why an exercise styling is better.
Yeah.
Sure. Okay. But CPAX ruling out, most of the time CPAX is stopped because of the patient not able to perform. those people who are using it can say better, but whether it will able to differentiate definitely from cardiac to pulmonary, very difficult in this patient who has both the disease coexisting. That's what I believe, that I may not subject
I
patient
guess
to.
what Amila meant was what was contributing more,
Yeah,
Asmita,
my
and
my worry is
your.
actually, I mean, what I feel he's most of the time is he might be deconditioned, which we
Yeah,
might be able to kind of diagnose. We would be able to easily diagnose from a CPEX. I mean, this
sure,
patient,
sure.
just
Yeah,
pulmonary rehabilitation and doing some exercise weight reduction might relieve most of the shortness of breath. So I believe deconditioning could have been a major
major
factor
reason.
here
Sure,
in
sure,
this
sure.
case. I mean, we have to exclude cardiac definitely, but my guess is it's basically deconditioning.
Very good points. But it's very interesting, Sujit. I read a recent paper where
Right.
there are three stages at which physical decline happens very rapidly. And one of those ages is 78. So it's interesting that this man is 79 and you get a sudden dip in physical condition.
Yeah.
Wow, exactly the same. So maybe
And
you can.
it's also because now there are two centers in Mumbai doing CPEC. So I think I'll take Amila's point on board because we don't use it as often as we may. And
Yeah,
I think Amila thought about it being a 10K walker, tennis player. These are the people who can do a CPEX,
sure.
reasonably well.
Definitely. Yeah. Yeah.
Absolutely. Yeah. Thank you
Okay.
all. Thank you.
Thank you.
Thank
Thank
you.
you. And see you on 21st.
Thank you. Thank
Bye.
you,
Bye.
Asmita.
Thank you.
Thank you.
Bye.
Bye.